the realm of today's presentation. What I'd like to do rather is look at a practical way of how we can be looking at diabetic macular edema, depending on what modalities we have to be able to diagnose and manage the condition. And so the classification of diabetic macular edema has changed over the years, and that has largely been due to the changes that we've seen over time. So there's an improved understanding of the pathophysiology. So we now better understand the role of VEGF and the role of inflammation in diabetic macular edema. There have also been great advances in imaging. And I think one of the most important advances, particularly for the management of diabetic macular edema, has been the OCT. And that allows us to see things that, parts of the retina and detail in the retina that we could not see before. And then there have been changes in treatment over the years. Previously, in the early days, macular edema was only treated with laser. But now, largely, that has been replaced by intravitreal steroids, intravitreal anti-VEGF, as well as intravitreal steroids. And so if we go back to the beginning, prior to sort of the 1980s, there was no treatment for diabetic macular edema. And it was really the ETDRS study, the early treatment of diabetic retinopathy study, that in 1985, they published this landmark study that showed that macular laser photocoagulation could reduce the risk of moderate visual loss by 50% at that 3-year endpoint. And another important thing that this study did was give us a definition of what clinically significant macular edema was. And essentially, there were three points to the diagnosis or the classification. The first was if you had retinal thickening at or within 500 microns, or 1/3 of a disc diameter of the center of the fovea. The second was if you had hard exudates at or within 500 microns of the center of the fovea with adjacent retinal thickening. And then the third point was a zone or zones of thickening, which were more than one disc area in size, where any of the thickening is within one disc diameter of the fovea. And so if you had any three of those features clinically, and this was done by looking through the slit lamp. So this was slit lamp biomicroscopy before fluorescein and OCT. And these patients were deemed to benefit from laser. And then we had greater advances in imaging, and the first was fluorescein angiography. And with fluorescein, we're now able to then see the focal areas of leaking aneurysms. And with fluorescein, you're able to now target the leaking aneurysms better than you could with just fundus photography or slit lamp biomicroscopy. And we're also able to see diffuse areas of edema. And at that time, grid was applied to these areas of diffuse edema. And then optical coherence tomography, OCT, was one of the great advances. And this was great because now you got a cross-sectional view of the retina, and you're able to see all the layers of the retina. And you could tell then which was a center involving edema and which was non-center involving edema. And this, the OCT was then overlaid by the ETDRS grid. And you can then see that central 1 millimeter, overlaid on the image of the grid. And that is really helpful because then you can definitely see whether it involves a center or not and how much is involved. And over time, you can compare between previous OCTs to subsequent OCTs as to how the patient is responding to your treatment. Because just looking with the slit lamp, you can't always tell how much thinner the retina is and how it's responding to treatment. So the OCT has been great in terms of one of the great advances in managing this condition. And then we come to the diagnosis. So in order to manage diabetic macular edema, we first have to diagnose it. And the first thing is to get an assessment of the visual acuity. And most patients, the first indication that they might have a DME is a drop in visual acuity. So patients should have a visual acuity done at each visit and each follow-up visit. The visual acuity is helpful to also monitor patients' response. And also it can be used to decide whether you want to treat a patient with DME or not, because observation is also one of the options. And then we can look at the retina using a slit lamp and a 90D or 78D lens. And you can clinically see the area of thickening. You can see the associated exudates as well. But this is not really a very efficient way of looking at large groups of people and for screening large groups of people, which is really what we want to do if we want to catch as many people and manage as many diabetics as possible. And so this is where fundus photography is really very helpful, because this doesn't need to be done by the ophthalmologist. And you can train different cadres of healthcare personnel to be able to take the pictures themselves, and then these can be transferred to an ophthalmologist to be able to interpret. And these days, there's even AI programs that can assist us so that we can know then which patients to refer and which patients do not need to be referred based on criteria that are created where you work. And then I think the OCT is probably the most valuable tool that we have in diagnosing and managing macular edema. And with this, we can see more accurately, as I said, whether it's center involving or not. You can also see the presence of biomarkers. There's certain OCT biomarkers. There's some work that is going into that can guide us on our treatment decisions in patients with DME. And because it's a cross-sectional picture, we are able to monitor from visit to visit the decrease or increase in retinal thickness. And then the fluorescein angiogram is great because you can see areas of leakage. Say if you've got a patient with focal psercinate in an area, and with an FA you can see leakage. And it's also valuable for looking for ischemia. And the OCTA can also be used to look for ischemia in patients. And so we have a whole armamentarium of different tools that we can use to be able to manage our patients and view which patients have edema and how much edema and how we can follow them up. So I'd like to pull up our first poll. So the question says, which of these modalities do you have? And you can just pick as many as apply to you. I'd just like to get an idea of my audience so that I know what people are using and what they're not using. So I think we have about 30 seconds for this poll. So you can just as many as you have. Okay. All right, that's very interesting. So nearly 80% of you use slit lamps, and I'm not sure the 20% how you're diagnosing your diabetic macular edema without a slit lamp. And a large portion of you have fundus camera, which is great. And it's really encouraging to see that 70% of you are using an OCT. And about a quarter or a third have fluorescein and FA. And yeah, it looks like more people have OCTA than have FA, which is wonderful. Okay, great. So this leads nicely into then the management. So now we've talked about the diagnosis, and now I'd like us to have a look at the management. And I've sort of created this picture from the early days to where we are now. And I've picked out just a few of the landmark studies. I know this is not exhaustive, and some of you may think that there's others that I should have included that I didn't include. But there's really been a big change, as you can see, in how we managed diabetic macular edema over the past, say, 40 years. 1985, the ETDRS was published, and that established macular laser as the gold standard of treatment for macular edema. And then for many years, that was the only treatment available. There was, in the early 2000s, Protocol A was published by the DRCR network that showed a more safer parameters for the laser. And it also showed that we should be doing focal laser to the microaneurysms, which previously wasn't done. And so that was an important addition. But for nearly 20 years, macular laser was the only treatment. And then in the early 2000s was the era of the anti-VEGFs. And it was really the DRCR.net Protocol I that showed that ranibizumab was better than focal red laser alone. And then after that, there were a whole lot of studies with the different anti-VEGFs showing which ones worked. And initially, though, it was used against laser, but then subsequent ones, because the advantage of using anti-VEGFs had been established, and subsequent studies were compared to sham. There were also the FAME and the MEAD studies, which showed that intravitreal steroid implants work in the management of diabetic macular edema. One of the big landmark trials was the Protocol T. So after it had been established that all of these anti-VEGFs work, it wasn't clear about which one to choose. Now we know that they work, but now we've got so many, how do we know which one to choose? And Protocol T compared ranibizumab against bevacizumab and aflibercept. And it showed that all three anti-VEGFs work. And so this was great, because then you knew that, whatever you had available to you, you could use. The one thing that it did show, though, was that aflibercept seemed to work better in patients with an initial poor visual acuity. And so we're now at this point at present where we have anti-VEGFs that have been shown to work, intravitreal steroids that have been shown to work, laser has been shown to work. And now, we are using those agents in combination, or depending on what you have access to, because we know that they all do work, and some better than others. And in the management of diabetic macular edema, we need to make sure that we take a holistic management to the approach of macular edema. And we need to make sure that we control the underlying risk factors. Anti-VEGFs are now first-line treatment for center-involved diabetic macular edema. Steroids are also being used frequently, and in some cases are being used as first-line. They're more commonly probably are being used for refractory DME. And macular laser, it's being used less and less, but it is still an option in the management of DME. And then there are some patients that may need PPV. So if they've got vitreomacular traction, they may need a PPV. So that leads us to our second poll. I'd like to know what treatment options you have available to you. We all work in different settings. Some have a lot of agents for managing DME and some have very few. So I'd just like an idea of the audience. Okay, so there's a bit of a spread. Um, they've got about a third of people who have VEGF, steroids, laser, the whole tooth. Some people don't have access to PPV, and I hope they are able to refer to somewhere where patients can get a PPV. I see there are a lot of people who have anti-VEGF and laser, but don't have access to intravitreal steroids. And very few people only have laser. And I'm glad that more people have anti-VEGFs than laser only, which is quite encouraging. So thank you for all your responses. So the first thing we need to consider in the management is the control of the underlying risk factors. So as ophthalmologists, we're doctors, and we need to realize that we can't be treating the ocular disease in isolation. We have to be treating it as part of the systemic management of the disease. And the HbA1c, or the long-term control of glycemic control, is important. So it's not enough just to get a glucose when they visit and say whether they're controlled or not. We need to have a long-term control. And then the blood pressure is also important, and it's also important to manage the hyperlipidemia. Because of the hyperglycemia, these patients already have a compromised blood retinal barrier. And so therefore, if their hypertension and hyperlipidemia is also uncontrolled, that because those things affect your vasculature, it's just going to compound the macular edema. So it's important that we don't treat the sugar in isolation. And then with anemia, you can get chronic hypoxia and an increase in VEGF. And diabetic nephropathy is closely linked to diabetic macular edema because you have microvascular disease in your kidneys, and you probably have microvascular disease in your eyes. And so those are closely linked. And then the last one is pregnancy. So diabetic macular edema can progress during pregnancy. So it's important that if a diabetic patient does become pregnant, that they get followed up by the ophthalmologist regularly to monitor for complications. Because if they do develop, we need to make sure that we pick it up early and we're able to manage it. So the management is also another challenge if a patient is pregnant, because the question is, what do you give them? Because we really want to avoid anti-VEGFs. Anti-VEGF. And so the options you have are observation, and in some patients you could observe and hope that once they deliver, the ocular condition can improve. You can offer them laser, or you could consider intravitreal steroid. And the concern with steroid is these patients are young, they're usually phakic, and do you want to give them that added risk of possible cataract? So this is not an easy decision, but one that we need to consider. And so the control of risk factors is very important in our overall management and how we approach the initial management and the ongoing management of diabetic macular edema. And then intravitreal anti-VEGFs. So these are first line in the treatment of involved diabetic macular. They've been shown to improve vision, decrease retinal thickening in patients. Most anti-VEGFs are given monthly, so we give one injection every 4 weeks. And this can carry on sometimes for months. And in some patients, they require treatment for years. So once a decision has been made to give anti-VEGFs, I think it's important that the patients understand that it's not just a once-off intervention, that it's going to be a few times, and you don't know how long or how quickly they will respond. But anti-VEGFs are important in our initial management. There are different types of anti-VEGFs that are available to us, and different options. So bevacizumab or Avastin is probably the most widely used. It binds to VEGF-A. Others in the class are ranibizumab or Lucentis, which was one of the first FDA-approved anti-VEGFs. And brolucizumab has the advantage of having an extended treatment interval. And so that's the advantage of that. Aflibercept binds to VEGF-A and B, as well as placental growth factor, and it also has the advantage of an increased treatment interval. And then the newest anti-VEGF is faricimab or Vabysmo, and that has a dual action on VEGF-A and Ang2. Convacept I have no experience in, and I think it's used in parts of Asia. So with all these options of anti-VEGF, the question could be, now, which one do we use? And I think it's related to, one, the patient. What is the patient going to respond to? Patients respond differently to different agents. It could also be the treatment interval that might be a factor. If patients are unable to come monthly and would prefer a 2-monthly injection, and you have availability of, say, Eylea or one of the other agents that you could give 2-monthly, that might be a consideration. The availability is always important, right? So if you have whatever agents you have, or what you can offer the patient. And in our settings, you've always got to consider at what cost, because some of the other, so usually bevacizumab or Avastin, I think, is one of the most cost-effective anti-VEGFs are available. And if you're going to be offering a patient one of the other anti-VEGFs, you may need to consider the cost, because they may need subsequent injections. If they improve to that, if they respond to that agent, you may need to consider continuing with that agent and the cost of that. So it's not always a straightforward answer. There's many things to consider when you make this decision as to which anti-VEGF to use. And so you give the anti-VEGF and the patient doesn't respond. So what do you do if the anti-VEGF doesn't work? So not all anti-VEGFs work for everybody. And the literature has shown us that 40% of patients don't respond to first-line anti-VEGFs. And the first thing we need to make sure is that we're actually giving the patient enough time to respond. So just giving one anti-VEGF and then saying that the patient didn't respond is usually not enough. We usually have to give them, a few anti-VEGFs, and usually you're going to give them 3 before deciding whether they have not responded. And if there is an improvement, even after 3 injections, but they're not completely dry, I would continue. So you can continue. Some need, monthly injection for 6 months. But as long as you see that there is an improvement, then you would carry on with the treatment. Another thing to consider is the pathophysiology. So you've given them an anti-VEGF, but the patient may respond to a steroid because it's primarily inflammation driven. And so even if they don't respond to anti-VEGFs, it doesn't mean that they won't respond to another form of treatment. And then there's a variability in VEGF expression. Not all patients respond the same to all the anti-VEGFs. So you may give a patient, one patient may not respond to to bevacizumab, but they may respond to ranibizumab. And even though they're in the same class, they both act on VEGF-A, patient may respond to ranibizumab, say. So that is something to consider. And then the chronicity of the diabetic macular edema. So patients who've had macular edema for a long time can get structural changes to the retina, which can make them respond worse to the DME. And some patients, after a long time, they get these plaques in the macula, which are difficult to treat. If the anti-VEGF doesn't work, we also may need to investigate the patient further. And one of the things that we should be looking at is once, if we've done that OCT, we should look at the biomarkers. There's a lot of work that is going into OCT biomarkers. And on this picture, you can see those yellow arrows pointing at hyperreflective foci. And you can see this patient also has some subretinal fluid. So those are some of the biomarkers that we look at in deciding what treatment the patient should get. And so for patients with multiple hyperreflective foci, not just one or two, with these large intraretinal cysts, those patients seem to respond better to steroids. And so you might need to consider switching those patients to steroids rather. Drill is the disorganization of retinal inner layers. So that's when you're unable to distinguish the inner layers of the retina. So the ganglion cell, the inner plexiform, inner nuclear, outer plexiform layers, they're sort of a bit indistinguishable because usually on the OCT you can tell, the lines are quite distinct. And these patients also seem to respond better to steroids. And drill can happen with or without center-involved macular edema. Drill is the disorganization of retinal outer layers. And even with resolution of fluid, if the macula is dry, these patients can still have poor visual outcomes. So it's important to know that. So you may give the patient treatment, an anti-VEGF, say the retina is dry, but the patient still can't see. And then you look at the OCT, you can see that they've got features of drill. And then you need to explain to the patient why their vision hasn't improved. And then subretinal fluid. This can respond to either anti-VEGF or steroids. And so those are biomarkers that we can look at on the OCT that may explain why the anti-VEGF isn't working. And then the next thing is to consider whether there may be underlying ischemia. So the macula can be dry, but the patient still can't see. And if you look at this fluorescein angiogram, you can see that the patient has an enlarged foveal avascular zone, and it's very irregular. So this patient has an ischemic maculopathy. So even if you get the macula dry, the visual improvement is unlikely. The vision is unlikely to improve. And so it's important then to be able to counsel the patient and explain the visual expectation. The other thing to consider is doing a wide field angiography if you have access to that. That wasn't one of my poll questions, but you can see in this picture, sort of in the inferonasal area, there is a lot of capillary dropout, and that is an area of ischemia. And it's been found that if you can laser that ischemic area, it decreases the VEGF, and it can improve the macular edema. The macular edema can then respond. So we've looked at other reasons why anti-VEGFs don't work, but we may then need to look at other options other than anti-VEGFs and how to treat these patients. And we may need to change to another anti-VEGF. So just because a patient has not responded to bevacizumab, they may then respond, say, to aflibercept, or they may respond to faricimab. And so we may need to consider that. The other thing that we should think of is then maybe changing class altogether and move away from the anti-VEGF and give an intravitreal steroids, because sometimes some patients will respond to steroids. So the steroids that are available intravitreally for use are triamcinolone, dexamethasone, and fluocinolone. And with with steroids, they work on the inflammation pathway. So when you have diabetes, you have this hypoglycemia, a whole lot of biochemical pathways that are activated, and one of those results in hypoxia, reactive oxygen species, and inflammation with the upregulation of VEGF. And so the anti-VEGFs work well on the with the upregulation of VEGF, but they may not work as well if there's inflammation as well. And so this is where intravitreal steroids could be of benefit. And earlier we talked about the biomarkers, and some of them have been found, some patients with those OCT biomarkers have been found to respond preferentially to steroids. And so those can be then considered. So triamcinolone is available, can be given subtenon, suprachoroidal, or intravitreal, but for the management of diabetic macular edema, it should be given intravitreal. The problems with triamcinolone is that it has a short duration of action, and also we should be concerned about the complications, particularly cataract and increased intraocular pressure. The dexamethasone implant was first found to work in the MEAD trial. Was a trial that showed that this implant is effective in patients with diabetic macular edema. There was an improvement in best corrected visual acuity and a reduction in edema. This, because it's a steroid, it also has the effect, the side effect of cataract and ocular hypertension, but the risk is lower with the dexamethasone implant than with a depot of triamcinolone, because the dexamethasone is a slow release implant. And so in some patients, the effect of the dexamethasone can last up to 6 months. And so that's great, especially in patients that aren't able to follow up as regularly and aren't able to come for injections as frequently, because then, you've got a few months in which before they might need their next injection. And so we've talked about anti-VEGFs, and we've talked about steroids. And we always need to consider that when we look at the OCT, if we see a patient has vitreomacular traction, we might need to consider that they might need pars-plana vitrectomy. I personally still try and give them anti-VEGF first. And if they, if you see that they don't respond, there's no point in carrying on the anti-VEGF. Rather send them to a vitreoretinal surgeon for pars-plana vitrectomy. And then the last thing that I'm going to speak about is macular laser and the role that it can play even today. So the ETDRS study was the study that showed that macular laser is an option for management of CSMO. And it gave us a classification of CSMO. That's the one that I spoke about a bit earlier. And subsequent trials were initially, after the ETDRS study came out, were compared to laser. So anti-VEGFs were compared to laser, and they were used in combination or as rescue treatment. So the role of laser has been established. The advantages of using laser is that you can, you have one single sitting of treatment of macular laser. It can be repeatable. It has a lower cost overall. So the initial machine might cost you, but for each individual patient encounter, the cost overall is less than with interventions that we have. And it is also less follow-up dependent. With anti-VEGFs, the patient need to come every month for the injection. You can't have somebody coming once a month now, and then they come back 6 months later, and you know, and you expecting a response. Whereas with laser, you're usually not going to repeat the laser until after 4 months, and so you've got time to monitor the response. So focal grid laser is really now used more for non-center involving diabetic macular edema. I think for center involved macular edema, we should still be using anti-VEGF. And if you see an area, non-center in the periphery where you see like a nice succinate and with those leaking microaneurysms in the center, you can apply focal laser to that area, and the edema can improve. And you can see in the middle picture there, the picture on the right, a few months later with the edema having resolved. And then grid laser can be applied to areas of diffuse leakage or thickened retina. The problem, though, with laser is that we've seen other complications. And with laser, you get what's called laser creep, and where the laser scars can get bigger, and it can involve the fovea and cause the patient to lose vision. Even if the laser was not applied close to the fovea, with the enlargement of the scar, you can get paracentral scotomas. You can also get CNV, subretinal fibrosis as complications. And these, unfortunately, once the patient has lost vision due to that, the visual prognosis is quite poor. And so I'd just like to present a case. We've discussed the diagnosis, we've discussed management options, and I'd like to present a patient that we treated in our eye clinic, who's a 52-year-old female patient. She's been diabetic for 15 years. She was uncontrolled. She's also hypertensive, and a VA in this left eye was 675. We were actually treating her for center-involved macular edema with anti-VEGF in her other eye. And the question was, well, what should we do about this eye? This patient had a succinate temporal to the fovea. And so I know what we did, but I'd really like to know how you would have managed this patient. And so we'll pull up our last poll just to get an idea how you would manage this patient. And those are the only options. So the options are intravitreal anti-VEGF, focal laser, transplant vitrectomy, or intravitreal steroid. Okay, interesting. All right. So more than half of you would give the patient an intravitreal anti-VEGF, a third focal laser, 3% PPV, and 14% intravitreal steroid. So I'll tell you what we did. So we did focal laser. And I know there are some of you who are probably thinking, well, actually, there should have been a fifth option, and that fifth option should have been observation, because that is a real possibility. That, if you've got a patient with good vision and non-center involved macular edema, you can monitor them. But you've got to make sure that that patient is going to come back. And I think it was a protocol V trial. that showed that for patients with vision that was better than 20/25, even if they had center-involved diabetic macular edema, you could actually observe and you didn't have to treat. So those patients who said intravitreal anti-VEGF, it's probably a bit of an overkill for somebody with good vision and non-center involving macular edema. So, I don't know whether it's worth giving patient that risk of giving the injection when you could observe, and then give the injection if it becomes center involving and the vision drops. Then you ask, well, why did we give focal laser? I think the advantage of giving focal laser is if it's away from the fovea, and if the patient doesn't follow up, then at least you've treated that part of the macula, because that's another concern. This patient was not a local patient. The patient lived out in the country. And even though we were treating the other eye with anti-VEGF, we weren't quite sure long-term what that would look like and what the follow-up would look like. And then for those who said PPV, I would say no. It's a bit of, that's a bit of an overkill for non-center involved diabetic macular edema. And then a few of you said intravitreal steroid, and I would not give intravitreal steroid in a patient with not, non-center involved macular edema. There's also the risks of giving steroid that are unnecessary in such a patient. Okay, so that was interesting. So we've come to the end, and I just have a few closing remarks. The first is that we should remember that diabetic macular edema should not be treated in isolation. We should be treating the patient holistically and never forget to think about the management of risk factors. We should use whatever available options that we have to accurately diagnose diabetic macular edema and diagnose it early, and manage it with whatever modality we have, and try and manage that early and effectively as well. We should also consider other solutions. So task shifting. If you have a fundus camera, perhaps you could train some of your other staff to do it, so that the doctors don't have to be doing the fundus images. We are in a world in which teleophthalmology is a possibility. So if you don't have the required specialist where you are, you could establish some linkages with other referral centers, your referral network, to be able to send images or consult on patients with people who are elsewhere. These days, we have the availability of AI, and there are AI programs that can look at fundus photographs and can tell whether there is diabetic maculopathy or not, whether there is diabetic retinopathy. And so you can then, instead of referring all your diabetics for specialist care, you can then refer the ones that you're worried about. And then the last thing I'd like to touch on is the importance of advocacy. As clinicians, we're often the ones that have to advocate for our patients. And whether you're working in a center where you need to explain to the people that are purchasing the items the importance of getting an OCT in order to be able to manage your patients better, or whether it's the importance of having access, a continued access to anti-VEGFs, we are often the ones that have to do that. In some places that we work, not everybody understands the importance of eye care, and it's not seen as a national priority. And so we need to advocate for that. And so my take home is that working in low resource settings doesn't mean that patients need to lose their vision. We should try and make sure that we treat them early and effectively, and that our management should really be individualized to the individual patient, as well as the clinical settings that we are working in. Thank you, and we can open for questions. Let me stop sharing. Okay, so I see there are a few questions on the Q&A. So the first one is the treatment different for DME after vitrectomy? So no, you would treat them with anti-VEGFs or steroid. They would respond. The second one, good evening. What are the biomarkers that we should rely on to follow up DME? So the biomarkers that we talked about are hyperreflective foci, the intraretinal cyst, it's disorganization of inner retinal layers, disorganization of outer retinal layers, subretinal fluid. And there should be none of the above. Oh, I'm not sure what that was. What is the significant role of clinical optometrists, not commercial-based optometrists, play in the role in monitoring and managing diabetic macular edema? I think it's very important for optometrists to get involved. I think it's really critical in being able to screen those patients, because depending on, on how many, the ratio of optometrists to ophthalmologists, you may be, it may be easier to get to optometrists than it may be in getting to an ophthalmologist. I think once an optometrist has managed to pick up a patient with diabetic macular edema, then they should be referred to an ophthalmologist as quickly as possible. And I think it's important then to be able to, to have ophthalmologists that you're working with to manage these patients. What is the management of PDR with DME? Laser followed by injection or vice versa? So this is always an interesting question. And so there's been a lot of, there's studies. The DRCR network has actually done studies which show that anti-VEGFs work can be used as a treatment for PDR. And so I generally would, if they've got diabetic macular edema, will start with the anti-VEGF, and then followed by laser. But if you can do them close together, I would do that as well. I don't think there's any real one answer. But if you've got a patient that you're worried is not going to come back, then you actually just want to laser them, because you don't want to see them the next visit and they've already got neovascular glaucoma because you gave them one anti-VEGF and they came back 6 months later. So some of these need to be. It depends on your patient, but I generally would start with the injection. How can we prioritize patients for anti-VEGF therapy when drug availability is inconsistent and patient demand is high? So that is a tricky one, because with anti-VEGFs, we don't know how quickly somebody is going to respond. And I think patients with chronic DME and those huge plaques in the macula, I would not prioritize. And you want to prioritize patients that are going to come back for follow-up. So if a patient has been shown to be uncompliant in the past, then perhaps those are the ones that you shouldn't prioritize. So I think perhaps it's important, depending on where you live, to set up a sort of a guideline as to who you feel would benefit most. The next one just says laser. At what point or case should we choose between anti-VEGF, laser, steroids, and combination? I think I've spoken about this. It also depends on whether you have, many countries have guidelines as to which agents they can use when. If you can use anything that that is available to you, then you would have to look at the patient and then decide on how the patient has presented. So if, for example, you've got a pseudophakic patient who's got multiple hyperreflective foci on OCT, large intraretinal cysts, and you could consider then steroids initially, if you have a persistent supply of steroids, because they may need more than one injection. So this has really got to be based, if you've got everything available to you, on how the patient looks. I am curious if there are any cases with patients with vision problems that has the same situation or same images that is the same with DME patients from normal patients with visual problems. Any cases with vision problems that has the same images? I'm not sure I understand the question, Anonymous. I would like to know the role of fundus autofluorescence in DME diagnosis and follow-up. I find that fundus autofluorescence doesn't really add that much more to how we diagnose, and particularly not in how we follow up. What is the most effective treatment algorithm for center-involved DME? Laser first, steroid first, or bevacizumab first? So for center-involved DME, I would not do laser first. I would either give them an anti-VEGF or a steroid. Hi, I'm Robert from Rwanda. I'm asking why during PPV we need to cut through pars plana. So if you think about the anatomy of the eye, that is where you can gain access to the retina without damaging the actual retinal tissue and without being too anterior, where now you're hitting iris and the anterior segment. So it's a technical question. Is there an association between diabetic foot ulcers and DR? So these are all complications of diabetic disease. So we know that once somebody is diabetic, you can have all sorts of complications. So you can develop, we often see cataract early. You see diabetic retinopathy. I talked about diabetic nephropathy. You can get foot ulcers. You can get multiple complications. Is anti-VEGF isn't contraindicated to pregnant and nursing mom? Yes, I think that's what I said. I said we would not give anti-VEGF in patients who are pregnant. So I would choose one of the other options. What is the best management to give out to our client if they are financially constrained? Well, I think that depends on the situation in your country, because I'm not sure what patients pay for. So you would have to really decide that based on what the financial model is in your country. From your experience, which is preferable, especially for African patients, monthly fixed injection, treat and extend, or per need anti-VEGF injection? I don't think this is particularly for African patients as to what you would use. It would really be based on how the patient responds. And I think a lot of the studies were done on monthly fixed injections. But I think if you do see that the patient has responded, then you can try and extend the injections. And if patients are available to come for regular OCTs, then you can consider PRN. What will influence the prognosis for using each of the management options given? The prognosis. So it all depends on how the patient presents. And so you will choose based on what the clinical picture is. And the prognosis you can't really tell until you've treated the patient, unless you know that the patient has an ischemic maculopathy. Then you can tell the patient that the prognosis is going to be poor. When to stop the anti-VEGF? So you can stop them once the visual is improved and the macula is dry. Good afternoon, lovely session. What is the mechanism of action of anti-VEGF and possible side effects to look out for? So I think I spoke earlier about when you have hypoglycemia, the whole lot of biochemical factors that come into play. You have the release of the cytokines and chemokines, which result in the upregulation of vascular endothelial growth factor. And so these anti-VEGFs work against that to decrease vascular endothelial growth factor, which is why they're called anti-VEGFs. Possible side effects. I think the most worrisome side effect is endophthalmitis, and that's usually the biggest side effect that we are worried about. And to decrease the risk of endophthalmitis, you want to give povidone iodine in the conjunctival sac before the injection. Do you recommend carbonic anhydrase inhibitors? No, I don't use carbonic anhydrase inhibitors for diabetic macular edema. Assuming you put the patient on first-line therapy anti-VEGF and the initial you choose is not working, when do you make the switch between the different anti-VEGF agents, and how do you choose the initial agent to begin with and which agent to switch to? So it depends what you have available to you. So I only have access to bevacizumab or Avastin. So that's going to be my go-to. But I think if after 3 months you don't see a change, then you would consider using one of the other anti-VEGF agents. One of the studies showed that if the patient had an initial poor visual acuity, and so if you have a patient with a visual acuity less than 20/15, you might then consider changing them to Eylea or changing to faricimab, because that has it acts on different target centers. How many anti-VEGFs are given before switching to another anti-VEGF in case of poor response? I would give at least 3 before switching. How accurate is the diagnosis of AI in retina? It all depends on the AI system you have, and a lot of them will let you know how good it is and how accurate it is. But I think the AI systems are getting better and better all the time at being able to pick up diabetic retinopathy and maculopathy. What is the mechanism of action for the laser? So we're not really quite sure how the grid laser works, but with the focal laser, you're really applying focal laser to the leaking microaneurysms and hopefully stopping the leakage on that aspect. A South African tertiary state hospital retina clinic experiences overwhelming diabetic retinopathy referrals, prolonged waiting times, limited intravitreal drug availability, and inadequate rural screening programs. A 57-year-old patient with bilateral center-involved DME, HbA1c 13%, chronic kidney disease, and inability to attend monthly visits presents for care. How would you develop a pragmatic, evidence-based management strategy that balances individual patient needs with public sector resource allocation constraints? Wow, that is a deep question, and I think it depends on what you have available to you. So it says you have limited intravitreal drug availability. So one of the things that I've noticed here is that this patient is systemically uncontrolled. So that is one thing that needs to be managed. And then you need to decide whether you should start the patient on anti-VEGF, and then monitor how that patient does. So, I mean, I think most of us work in resource constrained environments, but we need to consider, our patients individually as well and what would work best for them. Can anti-VEGF be routinely given in a setting where there is no OCT to follow up resolution of edema? I think it'll be difficult to decide how the patient is responding to your treatment if you don't have an OCT, because visual acuity is not a very good way of seeing if somebody is responding. And just looking with the slit lamp, you don't always see if the retina, if the edema is going away. So I think it's quite difficult. Which type of laser machine do I recommend? Yeah, it all depends on what laser machines are available in your country. So that's not a very easy question to answer. For the first case, may you please go through analysis of the OCT macula shown on the case? I'm not sure which one. I think it was the one where I said the patient had non-center involving diabetic macular edema. Well, the OCT isn't here, but if you see that on the OCT, it's got like this round grid, and then in the middle, there's a center circle, and that is the central 1 millimeter of the macula. That's assuming that, that the image is that you've captured a good OCT. And then you can see whether it's in the center or if it's not in the center. L'impact du CV en cas de rétinopathie diabétique. CV. I'm not sure what CV is. I think retinopathy diabetic is diabetic retinopathy, but I'm not sure, Ali Sauda, what CV is. Yeah, interpretation of the OCT, I think, is out of the reach of this talk. In the absence of OCT, how best to monitor patients if you want to give intravitreal injections? I think we've answered that one. If DME is not center involving, use focal laser. If DME is center involved, use anti-VEGF or steroid. Can I take it like I mentioned? Yeah, I think that is a good approach. I mean, unless you've got unlimited resources, and so, but that is one approach, and that is the approach that we use. Can focal or grid laser photocoagulation still play a clinically relevant role in DME treatment in settings with limited anti-VEGF access and inadequate imaging facilities? Yes, I think that you can. If you don't have anti-VEGF and all you have is laser, then use laser. Hi, Dr. Mbambisa. How do you know when you can stop a certain intervention, especially intravitreal Avastin? Well, usually you want to make sure that the patient is dry and that they that the vision has improved. But because diabetes is a systemic disease, we probably, we find that some of these patients, you get them dry and then they come back and they've reaccumulated the edema again. So diabetes is a chronic disease, and it's chronic management. What are biomarkers that tell us to use steroids? I think we've talked about the biomarkers. Is yellow laser a safer option in the African population in comparison to other types of laser? I don't know the answer to that. Can we give anti-VEGF after laser treatment? Yes, you can. Can OCT biomarkers help us identify which DME patient would respond to an intravitreal steroids? Yes, I think we have talked about that. Is there irreversible complications of intravitreal and VEGF? So I think the worst complication is probably getting endophthalmitis, and I don't think it's irreversible. If you catch it early enough, you can treat it. Can systemic steroids help with DME? No, not oral. I mean, I assume you mean oral or intravitreal steroids. So if you're going to give steroids, you have to give them intravitreally in the eye. When to change from anti-VEGF to steroid? I think we did discuss this, but if patients are not responding to first-line anti-VEGF, and or if you see certain biomarkers that you feel would be better responsive to anti-VEGF, I mean to steroids. How come intravitreal steroids are used in the management of DME and not NSAIDs, given the side effects of prolonged steroid use? I think they work differently to NSAIDs. So that's why you use steroids rather. In the case of chronic DME for years, what is the next and better treatment after several anti-VEGF steroid injections? Yes, that might be a possibility. Do you have any insights regarding the efficacy of high-dose Eylea for diabetic macular edema? I think there's a lot of work done in, there's quite a few studies on the use of Eylea. What parameters do we check as we monitor progress on DME on treatment? So you want to see that the vision is improving, and you want to see that there is the retinal thickening is improving, that the edema is improving. How long should I wait to say one type of anti-VEGF is working? I'd say a minimum of three injections. Hello, I'm Malin. May I ask you about experience after intravitreal Avastin 3 time, then you switch to intravitreal triamcinolone. So when do you decide to shift back to intravitreal Avastin? Well, if you've made the decision to switch to a steroid, I would assume that that was because the Avastin wasn't working. If the Avastin is working, then carry on with the Avastin. I would only change to another agent if the agent that I'm using is not working. When to repeat OCT after anti-VEGF injection? So if you are able to do an OCT monthly, that's great. But usually I would, because I'm going to be giving the first three, every month, I would usually then do an OCT after that third one. And then depending on how they've responded and how the patient, how I'm going to follow up, would depend on how often I do the OCT. So I think that was the last answer. Thank you very much, everybody. And thank you so much for listening. It's been a great afternoon, and I thank Cyberside so much for the invitation. Goodbye, everybody. Enjoy the rest of your day.